Um, I think we need additional dollars to research new promising interventions or treatments. I can't say. I mean, there are a lot of good evidence-based treatments, non-drug treatments that are emerging, and that is very exciting to me. I don't know that we've discovered the magic bullet or bullets yet, or what the magic potion is for people, and maybe it's not the same for everyone, but I would love to see a situation where through Medicare annual wellness, that people are actually assessed for cognition, that they're diagnosed appropriately, and then they're referred within the medical system to some intervention as yet to be determined, like we do for diabetes, or some people who have diabetes, where there's some sort of prescribed intervention or treatment, non-drug treatment that people go through when they have this disease. And I don't think that we've discovered what that would be yet. And then perhaps there are other things that could also be funded that are evidence-based within the community that help people get networked into things that help them on the ground. I don't know. I think there's more room for more dollars to look at more alternatives. I think we need a cadre of alternatives for people who have the disease. We talk a lot about caregivers, and I know that's really important, but people who have the disease need to have treatments available to them as well as their care partner.
I think I've alluded to this before. I think we need a well-developed, widely disseminated non-drug protocol. And I think until we can hand that to physicians or to primary care providers and say, we understand that there's enough evidence that these are effective. And I think a lot of agencies could be involved in that process of actually disseminating that information. I see dual therapy as being so much more positive than monotherapy, and we talk about the failures of drugs therapies, but I don't hear people talking about the potential benefit of dual therapy, of handing both scripts, of really having a well-developed protocol. The evidence is there. I just think some agency, and maybe this is the beginning of that, hopefully, needs to say, this is what we know enough about to say is helpful, and here is this protocol, and we're going to hand this to you to use. We submitted a 150-page monograph to the Alzheimer's Association in 2007, in which we said at that time there was enough evidence to support this protocol. And some people have referred to that or used that, but the beginnings of that have been out there since 2007. So I think it's maybe time to say, yes, we can support this as at least being a protocol, and I think that's essential. Kind of not looking at the policy or the funding end, all of us, I think, can think about how we train people to do these interventions. And I think Susan alluded at this. Are you going to have a trained occupational therapist or physical therapist in every practice setting or in every small community? And obviously you're not. So how do we go about training people to do non-drug therapies? And we have actually in our little tiny program, we have 4 health disciplines who send students to us because it's been shown to be such a positive experience for them. If it weren't for us, where would these students get trained? And I don't think they would get trained. So I think the other aspect of this is how you make that part of a health curriculum, health professional curriculum, so that it's embedded in the health professional curriculum in an expected part of competency when people practice. And I think that's a component that hasn't been talked about a lot, but that I see from where the rubber meets the road end, we need to do if we're going to have people who can actually implement this broadly.
Thank you. So now we have some time for open discussion. So I'm going to look to you, and we have a microphone here, and I'd ask that you speak into that so that they can hear on the recording. So I'm going to look to you for any questions that you have of the panelists. Don't be shy.
Shannon mentioned recruitment and retention, but it seems like what you were talking about was recruitment. Could you say a little more about retention? Because that's a big issue for the ADSSP people.
With our dad, we've actually seen very good retention in the program. And that's also true for another program that we're translating in Washington, Oregon State, which is the STAR-C program that Dr. Terry developed. It seems to me that once caregivers and care recipients come into a program like this, they love it. The folks who are out delivering the interventions are really great people. They build fine relationships. There can be issues over whether the treatment program can be delivered in the time frame it's initially intended to be, whether the caregivers and recipients can make it work 8 sessions in 8 weeks, or if those have to be spread out, or there's logistical issues in delivery, but I haven't seen, and correct me if I'm incorrect, but the retention is a problem. It's more getting folks in the first place.
I totally agree, and I think one of the benefits of having a continuously running program is that this becomes part of people's lives. And we've had people who have been in my program since we started, since day one, for 7 years, and they begin to talk about each other like family. If somebody's not there, the first thing somebody will say, well, is there something wrong with Joe today? Or, that woman who has a German accent, she's not here. And they'll talk about that. We celebrated our 82-year-old's birthday a few weeks ago, and he said it was the best birthday he ever had because he was with his family. So I think it does become sort of a very meaningful group experience, sort of a family experience. If it's a continuously running program like ours, retention has not been an issue at all. As the hardest part is when people progress past the point of being able to participate in the program, and then how you help them separate. That's really the problem for us. It's not keeping people in, but what happens when they can't participate.
I'm curious about the exercise components of your interventions, like what you do to help people stay motivated and, as their function declines over time, making sure that risks like falls and that sort of thing are mitigated to the extent possible. Because it seems to me the exercise is one of, at least from what literature I've read, is one of the most promising things in terms of maintaining or slowing the decline in cognitive impairment.
What we've done with our dad is put a lot of effort into figuring out how these exercises that we're offering can be tailored to the individual level of dementia severity of the participants. So we have people all across the spectrum in terms of cognitive ability who are in here. And clearly some individuals are less able to do some of the exercises. And also there's a widespread in physical frailty in addition to the dementia severity that complicates things. So we're tailoring the exercises to the individual. We're working carefully with the coaches, who are the family caregivers in this case, to make sure they understand how to protect the person with dementia, to ensure that they're not likely to fall, that they're doing the exercises correctly, that they're not overdoing, that they're not doing with improper posture or position, that they might injure themselves. We make our trainers are available to be contacted by a caregiver if they're having any problems. If families have any concerns about the exercise program, we encourage them to talk to their physicians about it to make sure there's nothing that's being done. So we put a big emphasis on safety. And a lot of safety are things that you'd think would be common sense, but they don't necessarily occur to people. For example, if you've got someone on a walking program every day, well, you need to tell them you don't walk when it's 105 degrees outside. You don't walk when it's icy. You don't walk over sidewalks that are very rough and increase risk for falls. If you're a caregiver and it's torture for you to walk with your husband because he walks so slow now, maybe you need to have someone else in the family, another kind of exercise buddy who will walk, so that you're not trying to march this person along at a pace that's going to increase their risk for falls and injury. That if you have people who have been very inactive to begin with and you're starting them on a walking program, that you start them out slow so they're not at risk for developing a stress fracture or something from going out too fast, too far. So safety is a really important part. The other thing, though, in working with someone with cognitive impairment is, they might be happy to do the exercises on Monday and not so interested in doing them on Tuesday. And so that's part of the working with family member coaches to find ways to make exercise, first of all, a pleasant event. If it's something that's enjoyable for both parties, then it's more likely to be something that they're going to be able to keep going. But then there are some times that a person may refuse to do the exercises, just as they'll refuse to take their medications or take a shower, and if you ask them 30 minutes, in a different way, then they'll be happy to go ahead. So part of good behavior management training is also helping to coach and encourage participating in exercises. Lastly, I'll just say, in the new NIA-funded study that Linda just got, we have modified the RDAD protocol so that in this translation effort, the caregivers are also going to be doing the exercises with the care recipients. And we're going to be evaluating physical outcomes on the caregivers as well as on the care recipients. And so not just will they be coaching, but they will themselves be participating in the program, and it'll be interesting to see what kind of a difference that makes.
I think for us, we exercise that affected balance, had positive effects on balance, like Tai Chi. And the family members who don't come to the program will often come in and do the exercise with the person because they find it very beneficial, and the relaxation, the Qigong component, which is sort of meditative and relaxing, is very positive for them. If you can deliver an intervention that affects both people positively, think about the cost effectiveness of that. So the caregivers are also learning a lot of the same mechanisms as the person. Then I think doing the exercises in a group setting is really motivating. I mean, people see other people who might be struggling with a particular form, and they know it's not just them. And this particular exercise form can be easily adapted for a lot of different levels of ability. We have people who are on continuous oxygen, who use walkers. You can do sitting, Tai Chi, and Qigong. So I think it's thinking about your exercise form that you're choosing as well, and how flexible is that to be adapted. We don't hire anyone to lead the group that hasn't had at least 7 years of training in the exercise form. And I think that's really important because then they have the ability to adapt and to work with people. We just had a woman with a subluxated shoulder, and she was able to help her do exercises with those types of issues. And I think that's really important.
I wanted to pick up on your point, Dr. Bergeron, about training and make just a comment and ask you a question about that. I think that it's very critical and that there has been a lack of funding and attention to training all health professionals. And maybe this does relate to AOA's dementia capability concepts. But one of the biggest hurdles in translation that we've had is that, moving from an efficacy trial where you pick the best, people who have high levels of knowledge and clinical reasoning, and then translating and training a broader group, in our case, occupational therapists and physical therapists, we are startled by the lack of very basic knowledge. And that has added a lot of cost to translation and a lot of effort in terms of the number of days we have to train. So that's more costly for agencies and things like that. And I'm just wondering how or how all of us could think about ways of elevating training, whether it is implementing basic competencies about dementia and family caregivers, as, maybe we need accreditation bodies involved here, and that becomes part of, what is a standard. I mean, I think there's some basic minimal standards here that we should expect all health professionals, physicians, nurses, OTs, PTs, social workers, et cetera, to really grasp. Which, again, from a translational perspective, they would be coming into our programs with training at a much different level. So I don't know if you have any thoughts about that.
Well, I think looking at basic competencies is critical, and they're not embedded. And sadly, nursing last year dropped geriatrics as a major and said it would be diffused among other specialties, which was a blow to me, a sort of a backward step in terms of increasing competencies and making sure that people were able to provide the care needed. So I do think competencies are critically important, but I also think until we have protocols that we can say are ready for clinical use and clinical practice, it's going to be hard to build those competencies. So I see it as sort of a two-step process. We have to say that these are the protocols that we feel can be implemented broadly across clinical disciplines and practice, and then build those into some competencies. So I think we're not ready for competency definition and implementation until we have the protocols well defined and in place.